So I'm going to begin right away. I'm sure all of you know me. I'm Alexandra. I'm currently doing my fellowship in Toronto in Endourology and Laparoscopy fellowship. But today I'm going to talk a bit about transplantation. We do a lot of transplants there, and we have had a lot of experience with commercial transplants over the last several years. Now, this topic has been largely unrecognized by the medical community, but it is an interesting, evolving ethical issue, and it is the buying of kidneys by Canadians overseas. Now, commercial transplantation is defined, we define it as a kidney donation that has been done purely for monetary means and is completely non-altruistic. Now, this practice is illegal in Canada, although, there are a certain number of kidney transplants in Canada where there's probably an exchange of money between the donors and recipients. We just don't know about those patients. So today I'm going to talk about patients, Canadians, who have gone abroad, bought a kidney, and had a renal transplant, and when they were subsequently followed at St. Michael's Hospital. Oh, sure. Is this better? So I just want to thank the nephrologists and urologists at St. Michael's Hospital who helped me with this project. And I'll cover a couple of objectives today, and it should take me about 45 minutes. I'll first highlight some of the more dramatic cases of commercial transplantation that we followed at St. Michael's Hospital. I'll review our series over the last 6 years, and then compare their outcomes with our local patient and graft survival outcomes, as well as review some of the world literature and some of the more practical points that these patients face when having to buy or wanting to buy a kidney abroad. So this graph shows the number of living donor transplants that we do each year at St. Michael's Hospital, and the numbers have doubled over the last 5 years, and this trend mirrors the national trends, and it's largely due to an increased number of emotionally related donors. Whoops, my mouse is seen here, and these are the spouses and friends. And then at the top of the graph, I don't know if you could see that part. Did you see this before? Okay. So the emotionally related donors have been a large part of the increase in number that we've had over the years, but we've also had an increased number of paid donors up here. And these probably represent about 5% of our living donor transplants at St. Michael's Hospital. Now I'm going to show a couple of more dramatic cases. It's not representative of our group, and I'll show that to you later. There's this 37-year-old woman who went to Pakistan and bought a kidney, and when she came back 2 weeks after her surgery and was seen in clinic and had a bit of a wound infection, but by 7 weeks she was admitted to our hospital with basically septic shock, and she had a lot of pain around her incision and some purulent discharge. And you can see on CT that she had pockets of abscess collections around her kidney and in the subcutaneous tissue. So at this point, when she was admitted, she was brought to the OR for an urgent wound debridement and drainage of the abscesses. And you can see that there are a lot of areas of necrotic tissue. And one of the more interesting things, too, is a lot of these patients are shown together with this sort of running proline suture, which is a little bit shocking. And so she had that, and that's why the hatch marks are so dramatic here. And she went on to have her wound debrided, and it was cultured. It was left open to heal by secondary intention. And she grew a number of things, MRSA. She had a fungal infection with aspergillus in her wound and blood, E. coli, Enterobacter, and Pseudomonas. And post-operatively, she had another wound debridement. 3 months later, she actually had to undergo a transplant nephrectomy because she remained septic. And finally, even off immunosuppressants and with her kidney out, she expired at 5 months after her transplant of overwhelming Pseudomonas infection. Another case is a 64-year-old woman who had chronic pyelonephritis as the cause of her end-stage renal disease, and she was pre-dialysis when she went over to Pakistan and bought a kidney. She came back to Canada at 3 weeks post-op and went directly from the airport to the emergency room. And she was treated for multiple infections, including an E. coli urosepsis, herpes and thrush in her mouth, as well as a febrile neutropenia. And she was treated for this. Her immunosuppression was reduced. She actually returned several times with urosepsis and at 5 months was again admitted with urosepsis but developed seizures and status epilepticus. And this is a head CT performed at 5 months and shows a lesion in the parietal lobe here. And when you see something like this after transplantation, you have to rule out or at least consider the idea that this could be an invasive fungal infection. They are rare after transplant, but they have a very, very high mortality rate. And indeed, the neurosurgeon actually, who looked at that head CT, noticed that she had an abnormality on her chest X-ray, and they performed a chest CT and found multiple nodules here, and a bronchoscopy showed that it was indeed aspergillus. She was treated for the next month medically with amphotericin B, but the repeat MR showed that this lesion was just getting larger, and she subsequently passed away. This is a somewhat similar case. 32-year-old went to India this time and bought a transplant, returned 2 months later and went directly to the emergency room with bloody massive diarrhea and CMV colitis. He also at that point had a disseminated aspergillus infection in his brain and in his lungs. He actually got better with medical treatment. He was treated for all these things. After 6 months of antifungal therapy, he was taken off his therapy. One important point I just want to point out here, there, you can see that this actually looks like an infarct. And one thing to remember is that aspergillus is an angioinvasive fungus, and so it can actually appear as an infarct on imaging and should be considered after transplantation when you see an infarct. But 1 year later, even though he had been better for about 6 months, he re-presented with pulmonary aspergillus and was intubated. As well, he developed neurologic symptoms and had an obstructive hydrocephalus from aspergillus and subsequently passed away. And this is the final case I wanted to present to you. Is a 50-year-old pre-dialysis patient who went to Pakistan and bought a kidney and returned to our emergency room directly from the airport. And he had a stoma bag over his incision, and it was draining urine into his stoma bag. And he also grew E. coli from this urinary drainage. So it was decided to divert him, and a nephrostomy tube was placed in the kidney. And you can see, I think you can see here, there is an area of the ureter in the proximal, or the UPJ, that sloughed off, and there's extravasation of contrast around. So he was left diverted. He actually had a stent in by the transplant team in Pakistan. And even though he was left diverted, he continued to sort of progressively get more and more septic. And at 3 months, it was decided that he would have to have his graft removed. He did have a CT, and what was interesting was the surgeons, for some reason, didn't actually close the fascia over his kidney at the time of transplantation. And when his kidney was removed, it was an intraperitoneal transplant. There was some momentum wrapped around it, and the fascia wasn't actually closed. So he had his kidney removed. Now this guy, he's better now. It's been a year, and he's already talking about when he'll go back to Pakistan to get another kidney. So, I'm going to talk about the more complete picture of a series of patients who have gone abroad to buy a kidney and that we followed subsequently. We did a retrospective review of all of our transplant recipients over a 6-year period, and they were all Canadian residents who went abroad, bought a kidney, and then came back and were followed. And this is the number of patients per year that we were able to find. We had a total of 23 cases. Our review ended partway through 2005, so that's why I think we have a dip here. But it looks as though the numbers of patients going abroad is increasing. But we'd have to sort of follow that up a bit further. Of the 23 commercial transplants, 21 patients were included because 2 of these patients had a second commercial transplant during that period. The mean age was slightly younger than what one would expect for a typical transplant population in Canada. The duration on hemodialysis or peritoneal dialysis was 22 months before transplantation, although 3 patients were pre-dialysis at the time. There were 4 of these patients who were on the cadaveric wait list, and they had been waiting for a mean of 27 months. The most common cause of end-stage renal disease in this group, because they were so young, was glomerulonephritis, followed by diabetes. Now, the slide's a little bit messed up, but you can see here, this is where the patients originated from, and 95% of these patients were immigrants to Canada, except for one Canadian. And the yellow countries here on the right show the countries where they went to have their transplants, most commonly in Pakistan, followed by China, Iran, India, Turkey, and the Philippines. And our follow-up was a mean of 30 months. So most of our patients come back with some form of medical documentation. It's just that it's not very complete. It's usually a sort of a discharge summary by the surgeon. But from the patients that we have some information from, they would usually stay in hospital about 23 days in the country abroad. And of the patients that come back, most commonly, they're kind of told to go from the airport to the emergency room to be assessed. So we would see the nephrologists see some patients who are well, and they would send them home. But of all the patients that returned, 38% were what we considered medically unstable, requiring admission when they were seen in Canada. And those patients who don't come directly to the emerge, they're seen in clinic within 1 to 2 days because they basically run out of immunosuppressants and they need to get more from the transplant nephrologist. So I went over 4 of the cases earlier, and some of the other reasons were a lot less severe, like an ileus. Now, in terms of the immunosuppression, most of these patients get quite modern immunosuppression drugs. I'll just my phone. Turn that off. Is that bothering you? Oh, okay, it's okay. So 20 of the 22 patients received triple immunosuppression. They most commonly would receive cyclosporin, mycophenolate, and prednisone, which is very acceptable. 2 of the patients had received just cyclosporin and prednisone. Even so, there was a fairly high rate of acute rejection overall. Over 30% had an acute rejection episode. And to sort of define this more along a timeline, this graph up here is from the U.S. renal data system and represents the renal transplants in the States. And this is over time. You can see that earlier on, about a decade ago, the acute rejection episodes were a lot more common, and also they occur more frequently during the first 6 months. Now, in our patients, 6 patients had an acute rejection episode within the first 6 months, representing 32% of our population. And that's kind of more representative of what you would expect about a decade ago, and then it tapers off to more reasonable levels. Now, we don't know why, even though these patients were on modern immunosuppressants, why they had such a high rejection incidence. We don't really have any information on the HLA matching or the donor or anything, or even the cyclosporin levels and such. As well, the postoperative morbidities were quite high. 64% had a major infectious complication. 3 of these patients died of an invasive fungal infection. And I'll just show you, this is sort of a summary of all the infections that they experienced. Pyelonephritis, UTI was the most common, as expected. CMV occurred in 4 of the patients. Septic shock, and a disseminated fungal infection occurred in 3 of the patients, all with aspergillus. TB was contracted in 4 patients. 2 contracted pulmonary TB and 2 had a PPD conversion within 1 month of their transplant. Some other rarer infections that they experienced was a wound infection, pneumonia. 1 patient came back with a quite severe paraspinal and psoas abscess and osteomyelitis with Pseudomonas. I think this patient probably had this before her transplant, but it wasn't properly worked up. And 1 patient had herpes. In terms of the urologic complications, 55% experienced some sort of urologic complication. It's quite a range here. Wound infection was quite common. Perirenal infection occurred in 2 patients, and then some other various infections, including a stone. 1 patient presented in acute renal failure with a stone obstructing the ureter. And this resulted in about 30% requiring some sort of surgery. 1 had the P&L for the stone. And most shocking was that 4 patients required a transplant nephrectomy, and only 1 was for chronic rejection. Now, this is a Kaplan-Meier curve showing our patient and graft survival. It's not really a comparison, but what I just wanted to show you were that the most common cause of death in our group, which I've already sort of alluded to, was a disseminated aspergillus infection, which is quite unusual. And the cause of graft loss were, there are various causes here. But the most important thing is the comparison to our local donor transplant recipients. And this is the graft survival compared in the commercial transplant population with our local living donor transplant recipients, and this was statistically significantly different. At about 5 years, the graft survival in our commercial transplant group was about 50%, and in our local living donors, it was about 82 or 83%. As well, if you break down our local living transplants into emotionally and biologically related groups, which would, it's a better comparison to compare them to the emotionally related transplants who are not biologically related. Again, this was significantly different with graft survival as well as patient survival. And this is looking at graft function in those patients who had a functioning graft at 1, 2, and 3 years. Particularly at 3 years, you can see the graft function in the commercial transplant group was significantly worse than those of the local cohort. And overall, we had 56% of patients who had survived with good graft function at the time of follow-up. So just to summarize, we found that about 5% of our transplant patients went abroad and purchased a kidney, but it was associated with quite a high rate of severe systemic infections and opportunistic infections, resulting in death of 3 patients. There is a high acute rejection rate despite the use of modern immunosuppressants, and the surgical complications were very common. And we feel that our 1-year and 3-year graft survival and patient survival were not comparable to our local results or to those of the Canadian Organ Registry Group. So I went on to discuss this a little bit further. This is a pie graph showing the most common cause of mortality in people who undergo transplantation in the United States, and this is similar in Canada as well. You can see here that cardiovascular disease is the most common cause of death, both early on after transplantation when the mortality rate is highest, and this carries on years after transplantation. But in our group, infection was the most common cause, and what we don't know is how many patients went abroad, got a transplant, and died perioperatively, possibly from a cardiovascular event, and never returned to Canada. We have no way of knowing how many patients are part of that kind of group. But the fact that so many patients had an invasive aspergillus infection was a bit alarming, and it deserves a more discussion. Now, I couldn't find really any reason why aspergillus infections was so common in these patients. Aspergillus is the second most common cause of invasive fungal infections after transplant, after Candida infections. Overall, fungal infections occur in 5%, but invasive fungal infections occur much less commonly. But the mortality rate is very high, particularly if they have cerebral disease and pulmonary disease. Now, one thing I did find out was when there's high numbers of spore counts of aspergillus in the air or in the ventilation system, if there are construction sites nearby or renovations, this is the breeding ground for aspergillus, and patients who are exposed to these environments have higher rates of invasive aspergillus infections. And this has been shown mostly in bone marrow transplant patients and liver transplant. And there's a theory that in some of these hospitals in Pakistan and India that they may have high spore counts, but it's not really written about in the literature. They have shown that if you decrease the spore counts by taking out carpet and preventing, construction areas or covering them up, that you can decrease the rate of aspergillus infections. So why do these people go and buy a kidney overseas, pay thousands and thousands of dollars, and potentially risk their lives? Well, the obvious answer is that they don't want to wait on the cadaveric wait list. And they know that if they have a transplant sooner, not only do they improve their quality of life, but they actually prolong their survival. And I'll just show you here. This is some data from St. Michael's Hospital. And our cadaveric wait list number of patients on the cadaveric wait list has been increasing every year and continues to increase. Yet the number of transplants really don't come close to approximating the number of patients on the wait list. And what this means is that nowadays people are waiting 5 to 10 years for a transplant, and this is quite daunting to patients. They kind of consider this death while waiting, and they're well aware of the data, that's available on the internet from the Canadian registry and the U.S. data system, and they see that the survival probability of patients who get a transplant is much better than those who are on dialysis, either hemodialysis or peritoneal dialysis, and they kind of consider this, I'm going to just die while I wait to get a transplant. Now, it's not really fair to compare these patients on dialysis with patients who have received a transplant, because these patients are probably sicker overall than all those patients who were able to get a transplant. So there was a study published in the New England Journal of Medicine that compared patients waiting on the wait list for cadaveric transplant and therefore were well enough to have a transplant with those patients who have actually received a transplant. And if you consider the relative risk of death for the patients waiting for a transplant to be 1, patients who have been transplanted initially have a higher relative risk of death during the perioperative period. But by 1 year out, here at 365 days, the relative risk of death for someone who is transplanted is 1/3 of that of someone still waiting for a transplant. So that, in a way, they're kind of right when they think of it this way. As well, patients know that if they can get a living donor transplant, that they'll have a longer graft and patient survival compared to the cadaveric transplants. And this is from the Canadian Organ Replacement Registry, and here you can see that the graft survival is indeed better for live donors. As well, the patient survival is better. And so they want to also, improve their length of life. And some people want a preemptive transplant. We saw that in some of our patients. They actually go abroad to get the kidney before they ever go on dialysis. And I don't know if this is a true motivator, but they may have seen that preemptive transplants do have a better survival long term. So it's not very realistic, because those numbers are from transplants that are performed in Canada and the United States. And this is the kind of data that is out there for commercial transplants. Here on the left are the countries where these patients originated from. These are the number of patients that they were able to find who underwent a commercial transplant. And these are the countries that the commercial transplant was performed in. Now, the largest series was published from Israel of 540 patients. And they actually had pretty good 1-year graft and patient survival results. And they showed that this was not significantly different from their own local population. But if you look at all the series together, the range seems to be less than what would be expected from, say, the Canadian outcomes. And our series would suggest that, although there could be a somewhat selection bias with that. But one thing that is quite alarming is that the rate of complications or infectious complications, to me, seems a lot higher in this group of renal transplants. The first 2 papers did report a pretty high rate of invasive fungal infections. This paper had 4% fatal invasive fungal infections. As well, there's quite a high rate of Hep B and HIV infections. This large series had an almost 5% HIV infection rate, and this was published in 1997. So since then, I'm assuming that they're testing for HIV in India, but I guess I don't really know. But this debate is ongoing. There are a lot of papers now in the literature debating the justification of legalizing commercial or paid donors. And the ethical debate is interesting, because they sort of state that there is no really ethical grounds to deny someone the right to sell a kidney. Patients should have autonomy, and we should not tell them why they should be motivated to, what their motivation should be to sell their kidney. They have the right to choose what they do with their organs, and that's their argument. In India, where there isn't a cadaveric transplant program, the only option these patients have is to buy a kidney. they, to get hemodialysis in India, you have to pay for it yourself. So it seems to them the only way to save their life would be to buy a kidney from someone. And so in India, they feel that this should be legal, and not only that, it will simultaneously help someone who is poor overcome their extreme poverty. As well, they also state that the risk to these donors is very little. There are papers showing that the 20-year survival rate for donors is the same as that of the general population, and they use that as an argument. But there's also a lot of criticism, and to me this seems a little bit more realistic. At the way it is now, without any sort of government overseeing this process, there is a lot of exploitation of poor people, and they're almost harassed into, giving up a kidney for money by money lenders. Certainly in countries like India, I read some papers about that. And the middleman or the broker actually ends up keeping, a large portion of the money paid out by the recipient. As well, in places like India, having this large population of donors willing to give up kidneys has prevented, or they feel may have prevented, the country from establishing a national cadaveric program. And this really isn't an act of patient autonomy. These patients or these donors are not informed of what they're going to go through. They are often not even given the amount of money they've been promised, and they're probably acting out of desperation and their severe impoverished state. Now, to justify that side of the argument, there was a paper published in JAMA about the economic and health consequences of selling a kidney in India. And this was a survey performed in 300 patients who had donated a kidney in India. And what this author found out was that 96% of these patients donated their kidney in order to pay off debts, and that almost 100% of these patients had no motivation to do this to help somebody in renal failure. The average amount they received was about $1,000, and they used the money to pay off debt, to buy food and clothing. But what they found at the time of the survey, that the family income in this group of patients had actually declined by a third on average, and about 75% of these patients were still poor and still in debt. 89% of these patients reported that their health had deteriorated, and they went into more detail about that. And 80% would not recommend that others sell a kidney. So it supports the idea that they're not really making an informed choice. If they had known about the consequences, they probably would not have done it. So patients are seen by the nephrologist at St. Mike's, and they actually tell them that, yeah, we're going to go over to India or China to buy a kidney. And what the nephrologists tell them is they tell them that they don't consider it ethical and it's not condoned. And it is illegal in Canada to do that, but we have no jurisdiction over what they do in other countries, and they are free to do what they want. We do let them know that there appears to be a pretty high risk of severe infections and to perhaps even avoid certain countries. And then we really insist that they obtain their documents of the hospital stay so that we can review those when they come back. But we do assure them that we will manage them when they come back, and that they should see us as soon as possible when they return to Canada. We also give them their options. I don't know if it's the same here, but at St. Mike's, the nephrologist team will actually help bring a donor from another country to Canada. They'll help with the visa issues. The recipient's medical will cover their hospital stay and pay for their medical bills. So there are other options open to patients. Now, it was kind of interesting that, how do people go about buying a kidney? It's really easy. You just go on the internet, and these two sites are placed, I think one's in China and one's in the Philippines, and you can buy a kidney there. But there are private kidney brokers, mostly, from what I gather, in the Middle East, in India, Eastern Europe, and Africa. And you can go through these middlemen who will arrange a kidney donor for you. In China, about 90% of the you pay the hospital, but 90% of the donors are actually executed prisoners. And that's become a big issue. The WHO have become quite involved with this and are quite concerned. They estimate that about 6,000 to 12,000 people are executed each year in China. And a lot of the hospitals, make a lot of money from selling their kidneys. The selling of kidneys has been illegal in India since 1994, but there are studies that have shown that 60% of donor nephrectomies are still being paid. And from what I can tell around the world, these donors are really receiving only about $500 to $1,000. And the cost to the recipient ranges from about $7,000 to $200,000. In Pakistan, I think you pay about $7,000, but in China there has been some reports of paying up to $200,000. So I just want to show you, this is actually from our website, one of those websites, and this is for a transplant that you can get in the Philippines. And the office that organizes the transplants is actually, it says that it's in Florida, but you go to the Philippines to get your kidney, and they're offering a kidney from $35,000 to $70,000. So I guess if you have the money, you can get your kidney really quickly. And really, that's the end of my talk. These are just some conclusions. Are there any comments? Dr. Master?
Excuse me, the patient went out of the country right in the decrypting on candidates in Canada? Or?
Yeah, so there were 4 patients who had been put on the cadaveric wait list. And so they were cleared for a transplant. But a lot of these patients, I don't know if it's cultural or they just know that they can go to their usually their home country actually and buy a kidney, and they don't even really talk about getting a transplant here in Canada. It's somewhat, it seems to be a little bit cultural. They kind of know from their friends and family back home that they can go back home and get a kidney. No. They may have been. There was one who had chronic pyelonephritis that probably should have had her kidneys removed first or treated adequately for that. Dr. Rowley?
I'm just very careful about this, but it seems to me that ethically, what we're doing is trying to monetize body parts. And, so far these are all people who have agreed to donate things, and they may or may not work. But if we finally put a price on a kidney of $10,000 and whatever of $300,000, there's a criminal element out there who may start retrieving things from people without the donor's consent, which is a really scary thing. Which in 10 years down the road.
Yeah.
That's where money is made up.
Well,
money for your body part.
Maybe. And I wonder if that doesn't happen now. Certainly with the criminal or the people who are executed in China, they say they get informed consent from the executed prisoners, but they do. I read that in the newspaper last week. But the way it is now, that stuff probably already happens. And this is a huge industry for some hospitals in these countries. So the argument is to legalize it or somehow get some sort of government control or completely illegalize it. There are doctors who are practicing doing it. We're just not told that this is being done for money.
Alex, I think the other issue here is setting aside all the ethical reasons why this shouldn't occur, that we can't control and can't really counts for a little, considering the desperation of some of these people.
Exactly.
In countries which are where the transplants are being done, if you look at the quality of medical care outside of North America, it's really inconsistent. Even in Western Europe, hospital to hospital, the standards are so lax that you can go to some excellent hospitals from pretty lousy hospitals, and that's a good country. When you're going to places like India and China and elsewhere around, it is buyers aware. And even if you're getting a good transplant from a good surgeon, you still are getting hospital care in a terrible country.
And I think that's what's happened in that one series of 500 patients from Israel who went to India. I think they dealt with one hospital in India. They had a special relationship, and maybe that's why their numbers were so good. But for our patients, I think it's quite a lot. It's quite random. I didn't have any patient go to the same hospital. They all went to different hospitals.
Alex, is there any documentation of actual morbidity and mortality associated with the donors?
The only paid donor paper I found was that one published in JAMA, and it was a survey of donors who were living. But I guess that's, yeah.
There's another paper on donors
Okay.
in Renal Urology. It's a couple of years ago, and it's from Iran. And actually, it's a survey, and the bottom line is that the donors were asked if they do it again, and a very vast majority said no.
Yeah.
It wasn't worth it, and they're not going to go through it again.
Yeah. Good thing. Dr. Burley?
Hi, Alex.
Hi.
You said in the comments about when you counsel these patients before they go,
Mm-hmm.
that they were going to avoid certain countries.
Yeah.
But you said,
Well, so this is just something one of the nephrologists told me. I don't know if all the nephrologists say the same thing, but they kind of recommend that patients don't go to, say, Pakistan in India. But I don't know how they say this to the patient. I don't think the patients always have a choice because those are Pakistan patients, going there. So.
Do you have any information on, is it particular hospitals?
Yeah, we don't, because every patient went to a different hospital. I know which hospitals they went to, and they sound like, reputable transplant centers, the way that the letterhead says. But they're all different. So no, I don't know which hospitals are good or bad. Maybe the patients in Israel, they've found a good hospital to go to, but I don't know which hospital it is. It's pretty random.
Do you have patients about data on your patients who are abroad where they had been on dialysis in Toronto?
I'm sorry?
They had been on dialysis in Toronto at the same time waiting for a kidney, and then they went abroad for the transplant. Is this survivable?
I think if they'd been on dialysis in...
If they're waiting in Toronto
Yeah.
on the categories list for
Yeah.
years, and they told you your patient that went away for a transplant, body kidney, although the survival is worse than if they had about...
Yeah, no, we don't really have that kind of comparison. And the numbers wouldn't really be large enough to compare that. But the patient